Great. Good morning, or rather, I should say good afternoon, everyone. We've been playing around with this for a little while. My name is Mike Wareing, so I'm an ENT surgeon at the Royal London Hospital with my colleagues there, and welcome to the third one in our series of lectures that's been brought about, I suppose, by COVID-19. And what we're going to talk about this afternoon is the basics of myringoplasty. Now, myringoplasty is sort of one of those easy operations that registrars feel should be well within their grasp, and it's a bit like septoplasty. Probably the two most difficult operations in ENT are septoplasty and myringoplasty, because they're supposed to be easy, but they often aren't. An easy septoplasty is usually a septoplasty that doesn't really need to be done. Now, what causes holes? Why do we have patients who get holes in their ear? We're going to talk about myringoplasty today, not really about tympanoplasty, so really just about repairing the drum. And you've got two main groups, the patients who have trauma, so they get slapped on their ear or they poke a cotton bud or something like that. And of course, you'll probably know that 90% of traumatic perforations will heal up with doing nothing. And the reason for that is probably because they are normal ears with normal eustachian tube function, and they tend to heal up. There will, of course, be the occasional one that will have had a traumatic perforation, and either due to bad luck or possibly because of infection, or maybe just where the edges of the perforation turn over, they don't heal. And they may end up coming to see you and getting listed for myringoplasty. So that's one group. The bigger group are the patients that have essentially infection. They may have had an acute otitis media in a previously normal ear. They may have been someone who's always had troublesome ears, so their ear troubles go back to childhood. And that's one of the questions you always ask people. Did you have any trouble as a child? Did you have grommets put in? Anything like that. Otitis externa will very rarely cause a perforation in the ear. I've seen a few patients recently who've had bad fungal otitis externa, and one of the characteristics of fungal otitis externa going bad is when they start to get an ulcer on the drum, and that may then become a hole. The majority of these, however, do heal up. You'll be aware of the definition of chronic otitis media. So there are 5 categories. There's healed chronic otitis media, so a patient who's had a perforation that's healed up. Those, again, might be those patients who've always had trouble with their ears. They had trouble with grommets as a child, and things that have healed up. Then there's inactive mucosal, which is the dry perforation, or active mucosal, which is the wet perforation. And then inactive squamous, which is when you have a retraction pocket that may or may not progress to the condition of cholesteatoma. So what is myringoplasty? It's repair of an eardrum, and the indications are essentially the presence of a perforation. However, just having a perforation is not usually enough to make you want to close a drum. Probably the main reason is recurrent infections, and then possibly hearing loss. And hearing loss, patients with perforations have got pretty variable hearing loss. Some have got quite big conductive losses. Some have got very small conductive losses, even with what looks like quite a large perforation. And part of the assessment of the patient is always what their hearing is like. And the aims are to close the drum, therefore to stop those infections, and hopefully to improve the hearing. There will be some patients who have perforations that are pretty much inactive, and they're worried about getting water in their ear. They may want to do water sports. And that, again, would be a reason to consider repairing their perforation. So the very basics are essentially to fill the hole in. That's what you need to do. And in the vast majority of cases, we do this with an underlay technique. The picture down here is actually a picture off the Biodesign website. And here is a perforation, the edges of which are there. And then someone has laid a graft underneath, and the idea is that you get ingrowth of the epithelium, and it grows across this as a scaffolding. You'll all remember that the drum has got 3 layers, so we've got skin on the outside, we have mucosa on the inside, and the middle fibrous layer. and it's in some ways the graft replaces the fibrous layer. You can do what's called an inlay graft, where you try and separate. Usually in this part of the drum, you can separate the outer squamous layer from the fibrous layer, but it's virtually impossible to do that in this front bit of the drum. And one of the problems is that whenever you look at pictures like the picture in your bottom right-hand corner, it looks flat. The problem is the drum is an inverted cone, and from the umbo going forward, this bit starts to rise up and come back towards you. So it's quite difficult to tuck things underneath there. So what I've done is I've got some pictures of some holes that we'll talk about what we might do with them. And this first hole here, you'll see the hole here. It's a very small perforation. A second hole here, again with a bit more of a tympanosclerotic drum, bit of tympanosclerosis here and here, and this perforation that's here. All right, and you can see that the middle ear mucosa through here looks basically pretty intact. There's a bit of bruising on the drum here, but this would be, you would hope, a relatively straightforward one. You'd really want to try and think that you could get that to close, and that might be the sort of thing that some of the registrars would hopefully start off doing. This is a much bigger perforation, and again, I mean, it's a great view of the middle ear anatomy. Here's the chorda running across here. There's a long process of the incus here. The head of stapedius here. The stapes tendon here. Here's the malleus running down here. So you can see your edges of perforation are here. It's essentially, I mean, I suppose one would have to call this a marginal perforation. What you don't really know is whether or not there's any skin growing underneath the drum there. Here you can quite clearly see epithelium coming off the drum here. And something always to remember, and there were some very good studies early on, is that if you put a dot of ink on a normal drum here, it gradually works its way round and comes down the ear canal. And that takes a period of weeks and months to happen. But there is this constant migration that's going on. So here's the edge of the perforation, and here's a bit of tympanosclerosis that you can see through the drum, and there's also rather tympanosclerotic in this area here. This is another perforation. Again, here's the perforation here. Okay, this is the anterior part of the drum. This is the front of the drum, the front of the ear, and this is the back of the ear here. And here is superior, and here is inferior. And again, what you've got is you've got a relatively small anterior perforation that's there. You can clearly see here, which is the tensor tympani canal, okay? And you've got a bit of inflammation on the drum here and here, but a relatively small looking hole. And as we'll come on to discuss, this is really quite difficult to get closed. And then lastly, we've got a drum that we've put up that's again got an anterior perforation. Okay, so the perforation is around here. Here's the lateral process of the malleus, and this is the back here. Okay, and here we've got some pus here, and we've got swollen mucosa here. So this is a wet ear. This is a rather active mucosal disease, and we'll come on to talk to what we should do about that. How do you assess your patient? Well, you've got to look at the ear. I mean, I think it's always worthwhile lying these patients down and looking under the microscope. As we'll come on to talk about, I mean, the endoscope has got quite a lot of popularity, and people quite like using the endoscope. Now I tend to use the microscope for these things. And if you're going to operate under the microscope, it makes sense to examine the patient under the microscope, so you can see how much of the ear, how much of the drum you can see, what the anatomy is like, what their shoulder's like, how much their shoulder gets in the way or their chest gets in the way, because that may influence how you're going to approach it. Always worthwhile looking in the other ear. You want to see if they're a patient with just one-sided problems or whether they've got two-sided problems. You can consider the nose. It probably is worthwhile thinking about treating undiagnosed allergy or even diagnosed allergy. You may want to look and see if they've got nasal polyps, or if they've got bad nasal disease. It makes you a bit less enthusiastic about their ear. And again, you want to consider carefully whether or not you're going to make them better or make them worse. I certainly remember when I was a registrar, one of the first tympanoplasties I did was a success, apart from the fact their hearing got worse because they developed an effusion behind it. So I sort of congratulate myself on the surgical success, but of course the patient actually felt worse. Pure tone audiometry is mandatory. Here are some examples of some audiograms here. So this top one here, this patient could quite easily have perforations in both his ears. This side, this left-hand side, you could certainly have a perforation with hearing like that, and really, again, how much better are you going to make it? You have to remember when you're looking at an audiogram and thinking about what your surgery is going to do to improve it, is that a surgical success is a 10 decibel air bone gap. Okay, and we know that in the most favorable circumstances, which is with stapedectomy, you'll only get that in the best hands 80 to 90% of the time. So if you're looking at ears that have got cholesteatoma or have got lots of tympanosclerosis, then your chance of getting it good and perfect is correspondingly reduced. Speech audiogram. Again, it's a useful investigation. It's not one that we do that much in the UK. I think we probably don't do it quite as much as we should do, but it's a useful investigation just to check that if the sound is made loud enough that they can hear it, because you will see patients who complain of poor speech discrimination, and if you're thinking of your surgery to try and make their speech discrimination better, and they've only got 60% optimal speech discrimination, then you're on to a bit of a loser. This sort of audiogram, down in the bottom right again, this conductive loss is unlikely to be due to just a perforation. You'd certainly be thinking very much about an ossicular problem with that. Tympanometry. Of course, if you do a tympanogram in an ear with a perforation, you should see a flat line with a relatively large ear canal volume. One of the things you may find with patients who've got perforations is that they can't get a seal. And this can be because there may be an element of patulosity. Now, you may think, hang on, probably they've got obstructive eustachian tube dysfunction problems, but patulosity is part of eustachian tube dysfunction. And I've seen patients, again, who've had successful myringoplasty who can have patulous symptoms afterwards. And part of their eustachian tube dysfunction is not purely an obstructive issue. It can be a patulous issue as well. Imaging for myringoplasty is rarely necessary. I think that patients, for example, who have cholesteatoma, they've got cholesteatoma, you're going to operate on them, should all have a CT scan, really to delineate the inner ear and to show you the extent of the disease. Doing CT scans to diagnose cholesteatoma is probably a waste of time. You have to remember with cholesteatoma, the diagnosis is clinical and the treatment is surgical. Most patients with a perforation, you can see the edges of the perforation, and a CT scan is unlikely to be helpful. So then you list the patient for myringoplasty. You obviously consent them for all the risks, and more about that later. You may well consent for additional procedures. I certainly think that when you're consenting patients, you need to be not too specific about exactly what you're going to do. It may well be that you like to think that you will know every single step of the operation, but often things change throughout part of the operation, and you need to have the flexibility in the consent process to potentially change that. And what you're thinking about is what your planned approach is going to be and what your planned graft is going to be. So what are the grafting materials for myringoplasty? Temporatus fascia has been around for a very long time, and I think is the workhorse of grafting material. It's You can usually get quite a lot of it. It's pretty flexible. It does change shape and align itself with the drum. And it's also actually nice and thin, or it should be nice and thin. Again, whenever you're taking a temporalis fascia graft, you want to make sure you thin it down such that it's not a great big fat chunk of material, because that's not what the eardrum is like. The eardrum is thin. Perichondrium is useful. It's probably a little bit tougher. You can't get quite as much of it, but it's pretty easy to work with. Cartilage is very popular, and nearly always that actually means a composite graft with perichondrium. So you've got the cartilage and the perichondrium attached, and you can do various things with that. It may add some strength to the drum, certainly useful in retraction pockets. Cartilage alone, I mean, the difficulty with cartilage alone is making sure that you have all the edges covered. I put periosteum in. We use periosteum quite a lot for mastoid obliteration, using the periosteum that lies underneath the temporalis fascia. If you've run out of graft material, then someone who's had previous procedures, they haven't got any temporalis fascia left, they haven't got any perichondrium, then you can consider using periosteum. Again, it produces a very nice thin graft, but it can be quite difficult getting that without making a hole in it. Fascia lata. Again, if you're really running out of things of patient autografts, fascia lata use. But the trouble with fascia lata is it's pretty thick and is really more used for skull-based repair. Biodesign and porcine matrix are popular, particularly with endoscopic surgeons. I have no experience of these. And then we come on to the sort of interesting group here, which have some use usually for very small perforations. So fat and gel foam are used for what's called a fat plug or gel foam plug myringoplasty, where basically you just put a piece of tissue in the hole, and by stimulating the edge of the perforation, you hope that it heals up. You can put plastic or silastic sheet on the top of a drum, again before freshening the edges, and you can even put a grommet in. Sometimes a patient with a very small hole at the front bit of the drum, if you put a grommet in, I mean, usually when grommets extrude, the drum heals up. So that may be something that you can try. Very easy to try in the outpatients. I also mentioned paper. One of the things that I do use very occasionally is Rizla. So cigarette paper is particularly useful for traumatic perforations. So I had someone very recently who'd been slapped on his ear. He had a posterior perforation with a relatively small hole. You just put a piece of paper on it. The eardrum is probably going to heal on its own anyway, but the paper gives him his hearing back during that period of time. I'm just going to look at polls, see if we've got a poll. So most people, so perhaps half of our poll, we've got people who I'm really aiming this talk at, the people who've not done very many myringoplasties. So the next question is, how do you get into an ear? And there are three ways into an ear. Permeatal, and you can use the microscope, or you can use the endoscope to do this. You do, however, need to think about a separate incision to get your graft, unless you're using a xenograft. It's easy to get tragal perichondrium or cartilage. Temporalis fascia does, however, require a separate incision up in the hairline. And I have to be honest, I find taking temporalis fascia very easy through a post-oral incision, but I've never found it that easy taking temporalis fascia through a hairline incision. End-oral incision, I think, is a particularly good incision. You can do virtually all ear surgery through an end-oral incision. It gives you good access to the ear. It's easy to get all types of graft. It can sometimes be limited to with anterior portion of the drum. So if you've got a very marked anterior canal bulge, then you may have some difficulty with an endoral approach, and that's when you might be thinking about a post-oral approach. And going through the back gives you a different angle to get more to the front of the drum. It's easy to get cartilage from the symbiconcha. It's good for the front of the ear, but it's not so easy for a sequeloplasty. So again, that shouldn't really matter if you're just thinking about a myringoplasty, but you may have to remove a little bit more bone to get a good view of the stapes or the stapes footplate. One of the things I was taught early on is always have the drill available for a myringoplasty. Doing a bit of a canalplasty, removing the spine of Henle, making the canal a bit bigger, is really helpful for getting your instruments in and making the operation, just easier. So before you do the incision, what you should probably inject some local anaesthetic, and there are various ways of injecting local anaesthetic. The most important thing is probably into the canal itself, and with beveling the needle. So if you've got the needle like that, you bevel this bit. Here's the bone. So you bevel this bit against the bone, and you aim to try and elevate up the flap with your injection. So a slow and steady injection certainly helps. Again, before the incision, if you can get a good view of the drum, you want to freshen the edges. It may be possible to leave that until later, but you can't freshen the edges once you've started to get the drum up, or once you've got the drum up. And up recently was how did you get in? I think it's very worthwhile with the myringoplasty flap, putting your incision in first of all, because then you know how far down you need to dissect in the canal with a post-oral incision until you've got to the right area. It is possible to keep going down with the post-oral approach and get all the way down to the annulus quite easily. So this is an endoral incision, and basically there are three lengths here. So this first length here would be just a sort of a little endoral release. You might have some difficulty getting temporalis fascia out with that. You can certainly go to here if you want temporalis fascia, and if you want a bigger incision, then you follow it up here. It's important to try and avoid, I think, cutting the cartilage. So you really want to get in between the cartilage there and not to incise the cartilage, just to help with healing. Post-oral incisions, you'll all see patients in the clinic and you'll see patients that have had the red line here with this incision running around here and right in the crease. And I'm not quite sure why that used to be the flavour of the month. I think it's something to do with potentially with cosmesis, but it's quite difficult to sew up right in the crease there. So I tend to put it, again, if I don't want too much access, I'll use this black line here. And if you're doing a mastoidectomy or a combined approach tympanoplasty or something like that, then you would use the blue line. All right. And again, you have to remember that wounds heal from the edges, not the ends. So giving yourself adequate access is certainly worthwhile doing. If you want to take tragal perichondrium, this is the incision that you'll use. So the tragus is pulled forward, and you make an incision just inside the very top bit of the tragus, and that's hidden. And then you make an incision down here. Always worthwhile injecting that beforehand, and it's quite easy to get either tragal perichondrium separately, or to tragal perichondrium with the cartilage. And you can, in fact, it depends what you want to do. You can, in fact, take both. You can, in fact, take really most of the tragus out completely. But there is a bit of a cosmetic problem here if you lose your tragus, and some patients may not be quite so keen on losing that, particularly if they like to wear headphones. Okay, so let's look at this one first of all, and I mean, a very small hole. I mean, you have to question, why might you be repairing this? It may well be someone who wants to swim. They're unlikely to have much in the way of hearing loss with this. They may get recurrent infections, so it may be worthwhile doing. And part of the problem with this is it's almost every option is open. So you could, in the clinic, you could stick a grommet in. You could put some paper or some silastic over it with just rubbing the edge up there. Or you could go to the operating theatre, and under local or general, you could put a fat plug in. probably most of you have seen the cartilage plug, which is essentially where you take a very small piece of cartilage and you basically incise it and make it like a grommet. It's not really something I've done that much of. My concern is about getting the problems of myringoplasty on the outer surface of the cartilage. But I'm reliably assured it works pretty well. The other option that you can do is you can take a piece of cartilage like that, and you can use the perichondrium like that. And again, you can put the cartilage through the drum, and you can use the perichondrium to sit on the outside. And that I have done that a few times, and that works pretty well. The other option, again, you can always do is just do a regular underlay graft, which is what we're coming on to next. Okay, so this again is the perforation that we showed earlier. This patient will have probably a relatively mild conductive loss. They've had infections in the past, as evidenced by the fact they've got tympanosclerosis, and they complain of recurrent infections, and they've decided to go ahead with the myringoplasty. So you could do this in any way. If you've got a nice big ear canal, you could do it with a permeatal approach. You could do an endural approach with a small endural release, or you could even consider doing a post-oral approach to this if they've got a very difficult ear canal. So again, all options would be open, and you'd make that assessment before you started. So the process of it, the first process is usually to freshen the edges. I mean, there are some papers that say you don't need to freshen the edges. I think that I've had the occasional patient in which the graft has not taken, it's fallen down, and it's all looked very, very inert. And I think you just need a little bit of injury of the drum to start to encourage that epithelial migration. You'll probably, again, all have seen patients who have a perforation like this and have a little wavy bit of skin trying to grow across. But they very, very rarely seem to go all the way across. So to freshen the edges, I mean, what you need is you need something pretty sharp. You don't want to take out a huge amount of the drum. As a registrar, I certainly know most registrars want to take out virtually nothing of the drum not to make the hole much bigger. But if you use a slightly curved needle, basically you need a pretty good slightly curved needle. You need a slightly curved needle that's not got a bend on the end and is pretty sharp. A sickle knife can work if you've got a really good sickle knife. I actually find a very fine hook is quite a good way of just making a little perforation around here and getting the edge off. So the next thing to do is where to cut the tympanomeatal flap. And again, you might be sort of thinking, well, couldn't you just like do a little cut here and just shove something through there? That is almost certainly doomed to failure. I mean, if you're going to do that, you may as well not bother doing that. You may as well just put some gel foam through there. So you put some gel foam through there and push a graft through there. That would probably be easier than trying to do something here. But essentially, I think you need a relatively large tympanomeatal flap that comes all the way around here, and you make that incision usually with the round Rosen knife. And the things to look out for, in fact there's nearly always a suture line down here. Okay, so you need to make sure that you've dug out the skin in that area there. I always leave a bit more here than here. Okay, this bit has a tendency of rucking up. Obviously, when you're doing things like stapedectomy and you're removing a bit of bone around here, then you certainly don't want to have too short a flap. So you've got the suture line here, and then the next thing you do is you come down to the annulus. And what's easy to do is actually to start elevating the drum off the annulus. So you need to be very careful, and you need to really stay very much on the bone, and probably using your slightly curved needle to actually get the cartilage of the annulus out, because you want the drum to come up with the annulus. That's really important in these areas here, which again we'll come on to in a minute. But you don't want to take the you don't want to take the epithelium off the annulus here, because that's a sort of almost guaranteed way of getting a bit of blunting. So you've got this up, you've got the annulus up, the chorda will be lying across here. The chorda, sorry, lying across here. The chorda is an interesting thing. Sometimes you just have to look at it and a patient gets taste symptoms, and sometimes you take a pair of scissors to it and divide it and they get no symptoms. So it's difficult to predict what will happen. I certainly have done myringoplasties where the chorda has been preserved, you know, everything looks fine, but the patient has complained of taste disturbance. And the next thing to do, this bit of drum, this bit of skin up here is often a bit thicker, and it's usually worthwhile getting a pair of scissors in this area here to cut this portion of canal skin. Okay, so you've got the drum up, and then the next thing to do is to place your graft. So whatever graft you've got, you want to put some gel foam under the drum, and I've put just enough gel foam here. I mean, that's the tricky amount. There is a tendency to overpack. I've been to various places and people have said, you know, the middle ear is supposed to contain air and air alone. And therefore, I think you don't really want to put too much gel foam in. You particularly don't want to block a whole load of gel foam down here. So certainly not for a graft like this, because that will probably have a negative effect upon eustachian tube dysfunction. And then the question is, how big does your graft have to be? And you see here, I've actually drawn quite a reasonable size graft. And I've also suggested that might actually come up the posterior canal wall. And the advantage of that is that will hold it here and not getting it falling down. A lot of perforation, I mean, a lot of myringoplasties, they're going to fail. They fail because this anterior bit here has a tendency of falling down. And what you really need to do is you want to try and make your graft lie as smooth as possible up against the back bit of the drum. So this is a not so easy myringoplasty. I mean, I have to tell you, this patient did not have a myringoplasty. This patient had, was their only hearing ear, and we spoke about it at length, but they had no infections, no problems, and in fact their hearing was surprisingly good, and they decided not to go ahead. However, if we were to go ahead, then the question is, what might you do about tympanosclerosis? And you'd freshen the edges around here where the black dots are. This bit of tympanosclerosis, I think, would certainly have to go. The problem is what to do with this tympanosclerosis here, and there are two options. And you take a view at the time, whether or not you feel you can get your graft to lie nicely up against here, or else you're going to have to take out all of this tympanosclerosis, and then you're going to be left with basically just a very thin rim of epithelium here, and that would make it quite difficult. So that would depend upon what you might feel during the procedure. And then the question is, what sort of incision are you going to make? So if we have a look at this picture here, this would be the first sort of incision that you might make, and then you would extend it here. But if you're going to think about doing a pull through, and we'll come on to show you a picture of this in a minute, then you would need to end up with an incision either here or all the way around here. So you can lift the drum all the way up, and you can go underneath the annulus here and make a pocket, and that's where you can drag your drum through. So this is what we've done here. So this is the tempting thing to do. This one here is the tempting thing to do, is to try and get your graft to go under there. It's limited here by tensor tympani. But the problem you're going to have here is securing this graft in this area here. And you're going to have to put a reasonable amount of gel foam up there. And the problem is, in this area here, it starts to run up away from you. And you end up needing quite a lot of gel foam. So this is a technique to certainly think about on this area here, is shaping your graft like this. So you've got a graft, and you've got this anterior tuck here. Okay. And what you've done is you've gone through here.
Apologies, we seem to have lost Mr. Wareing. Oh, he's back.
Am I back on? Sorry, I just...
Oh, your voice is back on. Just need your audio.
Sorry, that's yeah. Just touched the wrong button on the mouse there, and that threw a bit of a spanner into the works. These new problems that we're being set. So sorry. So we said so. So you got your graft, and you need quite a big graft here, and this I think is difficult to get enough with tragal perichondrium. So you certainly might use some temporalis fascia for this. The other thing that many people would consider doing, particularly if you've ended up taking away quite a lot of this tympanosclerosis, would be using some cartilage to reinforce it at the front here. How are we doing for time? Getting on. So this is a seductively difficult myringoplasty. This looks easy. It's a relatively small hole. You could think about putting a plug in. The problem is you've got this bit here, and this is where the front bit of the malleus, where it's quite difficult to get these areas cleared. Again, a temptation is almost to just put some gel foam through here and to put a plug through here, freshen the edges. There's a bit of inflammation here. But the other option would be to think about a bucket handle, so to lift all of this drum up. You might stop here, and then you can get really into position and you can have your graft coming up again. Now again, in this area here, you don't want to separate the epithelium from the annulus in this area here, and your graft would go up there. And then the last thing about myringoplasty is about what to do with these ears that are like this. And I think it's always worthwhile trying to get the ear dry before operating on it. The problem comes, I mean, it can be very difficult. You know, patients come up for their surgery. You may even have written in the letter, you know, this patient needs to come and have microsuction and have the ear cleaned out before coming. And it often doesn't seem to happen. And sometimes they pitch up, and you think to yourself, well, I'll just go ahead. And the results are probably not that much worse. I mean, there's some, at least this is all actually fairly active at the time. But I think it's worthwhile trying to clear these up. And what you would do is you'd be guided by some microsuction, and certainly worthwhile taking swabs to see what's growing. You get all sorts of things growing in the ear. And then you treat that as appropriate with either antibiotics or topical agents. The one thing I have found that is quite useful for drying ears up is oral steroids. This is a mucosa. This is not just unlike your nose. We know that if you give patients with polyps or rhinitis or anything like that steroids for their nose becomes amazingly better. And the same thing happens again with some of these patients, is that by giving a relatively small dose of prednisolone, you can get all this mucosal edema to dry up, and that helps. And because part of the problem is that this mucosa is weeping all the time, so it's always damp. So if you can get it dry before surgery, then that will help. So what can go wrong with myringoplasty? Well, the main risk is that your operation doesn't work. The graft doesn't take. Here, someone has enthusiastically put some cartilage in, and the cartilage is lying completely beautifully, but there's a hole here, and there's a hole here, and it's fallen down. And I think this was one where someone just tried to put some cartilage in. At the end of a procedure, at the end of a myringoplasty, if there's still holes, it's probably not going to heal up. So you need to make sure that all the edges are covered up. Taste disturbance, we've spoken about, always worthwhile warning patients. Hearing loss, again, you would imagine that by closing their drum, the hearing should get better, and it nearly always does. But it is a risk with otologic surgery, and it is worthwhile making sure the patient knows that the hearing may get worse. And that may be due to all sorts of problems. It may be due to post-operative infection. It can, of course, be due to your surgery if you're clumsy, or if you, if you damage the ossicles. That's certainly a possibility. And of course, getting blunting and problems like that, particularly on this front bit here of the annulus, is not very good for hearing. Sorry. And then vertigo, pretty unusual. Facial nerve injury. Should you warn patients about facial nerve injury with myringoplasty? I suppose the answer is probably yes, but I think you have to qualify it to them. That risk is incredibly low. I mean, the main risk of getting a facial nerve injury is probably due to over-enthusiastic local anesthetic injection. Unfortunately, that is very much temporary. So that comes to the end of the end of the presentation. This is a very basic introduction to myringoplasty. I hope that people have learned something. If there are any questions, then I'd be more than happy to answer them. Myringoplasty is just not that easy. You need to practice at it, and great care is needed. I'd just like to do a little plug for the Lyon broadcast that's happening on the 18th and 19th of May. These have been going for a number of years, and this year is slightly different in that it's not live surgery, it's videoed surgery and then panel discussion. But you've got some super experienced people from around the world, and I think it's well worthwhile logging on to that, particularly if, of course, we're still in shutdown. This is my favorite cartoon, and thank you very much for your attention, and I hope you've enjoyed it.
Great. Thank you very much for that, Mr. Wareing. That was really fantastic, and I'm sure lots of people have learnt loads of tips on how to improve their myringoplasties in the future. Some questions. First one from Andy. When is the ideal time for an audiogram prior to surgery? 3 to 6 months, or do you not feel like you are bothered?
I mean, I think getting an audiogram sooner to the surgery, I mean, within a month of the surgery is probably ideal. All of us who do clinics will have seen patients who've had serial audiograms, patients with otosclerosis, patients with perforations, patients with CSOM, and they do go up and down a bit. I mean, the question, what you really want to know from an audiogram is whether the ossicles are going to be intact and what the hearing is like and what you're playing with. I mean, would I cancel someone if they hadn't had an audiogram for 3 months and they said my hearing is exactly the same as it always has been? The answer is no. I think you have to be, relatively sensible. I mean, pre-admission clinics are the ideal opportunity to get audiograms done. If you can manage it by any way, I think that you as an operating surgeon or consultant that you're working with would be grateful for an up-to-date audiogram. Every case is different. You have to ask the patient. If they say my hearing's got dramatically worse, then you really do want an audiogram. So what you don't want to get caught out with is someone who's had an inner ear loss in between the time you've listed them and so on, and then they come back afterwards and they say, oh, my hearing's got a lot worse, and then the issue will be whether or not your surgery has affected it. I mean, hearing loss is a risk of otologic surgery, and patients are always consented for it, and it may not be the fault of the surgeon. It may just be something that happens, but probably knowing as close to the time is best. All right.
Great, thank you. We've got a question from another North Thames trainee who says, which textbook would you recommend for preparing in your registrar years for the exam?
I don't know, I'm not preparing for it. I mean, I think you can read Scott Brown. You can read the American textbooks. Some of the stuff from Mirko Toss, manual and middle ear surgery, is very good. The problem is there's so much stuff online now that you can also get some of that. But I think there are some great videos online, and looking and watching at those will help as well.
Okay.
So I'm not sure, I haven't really answered that question, but because I don't know the answer.
Okay, well, thank you for trying. Another question. So when you are using paper or Rizzler,
Yep. So if I'm using Rizzler, I never use the first one out of the pack.
Why?
Well, because that might be dirty. So you always get the second one out.
Okay.
I mean, I suspect it's fairly clean. So anyway, but the question is, yep.
Question is, so do you freshen the edges in clinic, and how would you do that? Would you consider using silver nitrate?
I personally would never put silver nitrate on a drum. Okay, I mean, I did do it once, and I ended up with a perforation. The trouble with silver nitrate is you apply it and you just don't know how far it goes and how long it goes on for. Someone did some quite good research quite a few years ago at Northwick Park, I think, looking on noses, when you cauterize noses, how deep the burn is with silver nitrate. So silver nitrate, I think, is fine if you're in a mastoid cavity or you're up against bone, but I personally don't use silver nitrate. I would use it depends what it is. I mean, so the last one I did was this chap who had a traumatic perforation, and I sort of tried to fold the edge out a bit, but I couldn't really manage that well, and then I just put the paper on. If you've got someone, so that first hole that we had a look at, I think if you could just get the edge of it, if you just use an otological needle, again, you have to remember that the most sensitive bit of the ear is the deep bony ear canal. That's the bit you don't want to jab. If you jab that bit, they don't like it. The drum itself is actually surprisingly insensate. Okay, so that would be an option. But I think if it's a traumatic perforation, you've already got a damaged edge. If you've got a long-standing perforation, then I think just putting a piece of paper over it and hoping it's going to heal is probably optimistic.
Okay. Great, thank you. When you talked about complications of a myringoplasty, you put facial nerve injury in brackets.
Yep.
A question from the audience was, does everyone consent for facial nerve palsy, but more specifically, do you consent for facial nerve palsy?
I think I consent for facial nerve palsy because what with the latest rulings, Montgomery, etc., you are supposed to consent for. I mean, it's a recognised potential complication of myringoplasty. Because a myringoplasty could become something more complicated. You could end up with a cholesteatoma. I mean, you shouldn't really end up with a cholesteatoma. And the question is, what would I do if that were the case? I think in part of the consent process, it's worthwhile consenting patients that many other things may happen to their ear, and therefore it's probably worthwhile putting it in. But I think you just have to say, I've never had an unwanted facial, a facial nerve palsy inadvertently. Okay. I think it's perfectly reasonable to qualify that.
Yes. Okay. And can you explain? Next question. Can you explain blunting?
Yeah, blunting is where I can see the question here. I mean, at the front bit of the drum, there's a sharp angle. Okay, and if you get scarring tissue grows across that, which is what blunting is.
Can you just start again, just because there was a lot of feedback from the microphone?
Okay, is that from my microphone?
I think so.
Really? Okay.
I'm sorry, just that question.
So what's blunting? Blunting is where usually in the anterior port. So there's quite a sharp angle between the external auditory canal and between the drum itself. And if you get scarring tissue that grows across there, so if you get an injury in that area there, then you get blunting, and you don't want that because that has an audiological penalty. I'm going to assume most patients have seen things like a false fundus, where the whole essential deep canal has become filled with scar tissue, and blunting is just a very minor portion of that. But I think you have to be very careful to respect the anterior recess.
Okay, thank you. Okay, you can see Matt's question there. Is there a real risk of ossicular disruption when raising the tympanomeatal flap off the handle of the malleus, or is this fairly robust?
Off the handle of the malleus. I think you have to. I think you have to be careful. I mean, it's there's, you know, regardless of how steady your hand is, there's going to be some transmission of energy through the ossicles through to the inner ear. I mean, we've got a KTP laser, so the drum comes off relatively easily if you go up the malleus, but right at the umbo, it's pretty tightly attached, and using the laser can be quite helpful to get that off. But with all things, you just have to be careful. What did he put? He put what did Matt put? Is there a real? I mean, it's fairly robust, but you have to be careful. I mean, a lot of the time, I tend to try and avoid taking the drum off the handle of the malleus, because there's again a real risk of getting a bit of lateralization with that, and that isn't very good for hearing. And also, if you devascularize, you know, the end of the malleus, I've also seen that shorten as well. So, I mean, like most things in surgery, you sort of, in some ways, everything's there for a reason. You want to try and keep it as close to nature as you can.
Okay.
Right. Next question.
We're getting some great questions, and I think we should carry on with them. So, next question: what do you think of post-operative antibiotics? Do you think they're necessary?
If the ear is completely sterile, then the answer is they shouldn't be necessary. So I think the evidence that that antibiotics are necessary in post-operative ear surgery is pretty low. That doesn't actually stop people trying them or taking them. As some of my registrars will know, particularly if someone's got quite a lot of mucosal disease, I am tempted to give antibiotics, and I'm also tempted to give post-operative steroids, to reduce that mucosal edema and swelling. I mean, the downside is whether steroids have any negative effect upon wound healing. But those are the things that I would think about. But I mean, I wouldn't say that we would definitely give it as a matter of routine.
Thank you. So Manny has asked, how often do you see the Baffle effect, and how significant is this in your experience? I actually have never heard of that.
Okay, so the Baffle effect is when you have a posterior drum perforation, and the idea is that sound goes in through the round window at the same time as going in through from the malleus through the ossicles, and essentially you get a cancellation out effect in the cochlea. That's what the Baffle effect is supposed to be. There's some doubt about how much that is the case, but what we certainly do know is that if you have a posterior perforation, then you get a bigger conductive loss. And so these are the patients that are great. If you have traumatic perforation and they've got a hole in the posterior bit of the drum, and you put a piece of paper on, you make their hearing completely back to normal, and they're really grateful. So there is that Baffle effect, but some of that is also because there's more vibration of the posterior portion of the drum, so it's a bit more responsible for the hearing.
So how does that affect your decision making?
If you've got a small anterior perforation, you've probably not got much hearing loss, and your hearing gains are not going to be so good. If you've got a big posterior perforation, then you can expect your hearing gains to be quite good.
Okay.
I mean, that audiogram I showed earlier, that audiogram had about a 60 dB loss. That would be too much for just a perforation. If they had about a 40 or 35 dB loss, that could be the perforation itself. All right.
Yes. Next question from Carol. What
do I pack the EOC with? So after I've put the graft back, I tend to use gel foam. I tend to use dry gel foam, and I then place that very carefully. I suppose one of the things that we haven't mentioned is, I know I'm doing the Hillary pinch, by the way. one of the things that we haven't spoken about is gel foam in the middle ear. And I particularly if I think there's a bit of mucosal edema, then I actually tend to put a bit of betnazole on it, because I think betnazole probably helps in the middle ear. On the outer ear, so the drum's back, I just tend to put gel foam down, and then I tend to use a syringe, and I put a bit of ciprofloxacin drops on it. So I suppose that is using antibiotics to some extent, but that tends to make the gel foam form a sort of a bit more of a mass. I do use BIP still from time to time, but probably a bit less than I used to. I've seen a few BIP reactions. So sometimes you get away with just using gel foam and a piece of cotton wool in the ear. It'll also depend upon what incision you've used. I think if you used a post-oral incision, then some BIP in the lateral canal is helpful to keep the epithelium, the skin, back against the bone.
Okay, thank you. So Heidi's asked a question. If someone else's myringoplasty fails, how soon afterwards would you attempt to repair it?
Well, not before they've left hospital, I suppose would be the first answer. I think you'd have to leave it until until it looked stable. So that might be 2 or 3 months, 3 or 4 months. I mean, I guess all the registrars have probably seen some ear surgery post-operatively, but I think one of the things we don't tend to get the opportunity to do is to actually see our patients quite as much as you would like to see how it's healing up. But at 3 months, it tends to start to look pretty inert. Sorry, that's my phone. That is my phone. It says a little bit inert. So I mean, I would say probably with after 3 months.
Okay. So basically, no rush.
No rush.
Okay. Fantastic. I think we've answered all the questions from the audience. So thank you again very much for joining us. Thank you, Mr. Wareing. Thank you, Anna and Mr. Pawn.